Hi, I'm Alan Moses. I'm the inventor of X-Slant, a posterior stabilization guide to position the relevant airway parts to record the interarch jaw position for fabrication of an oral sleep appliance. Part 1, Why X-Slant is better than any available alternative, can be found on YouTube at the site listed on the bottom of this sheet. This talk is part 2 of a series on positioning airway parts for fabrication of an oral sleep appliance. Part 1 explains why X-Slant is important to achieve the most favorable position. Part 2 demonstrates how to do it using X-Slant. Obstructive sleep apnea is an intermittent malfunction of the central nervous system. In an obstructive sleep apnea episode, the tongue periodically collapses on the oropharynx, blocking airflow to the lungs. It is a passive collapse. It is not caused by pathology, tumor, trauma, or infection. Many patients have no pre-existing conditions. It's not all about appliance design. It's really about positioning the airway parts so they support the largest airway. It is a complex, three-dimensional position. Oral appliances move and position the adjustable airway parts to dilate and stent the largest possible oropharyngeal airway opening. Registering or recording the optimum physiologic interarch relationship for an oral sleep appliance has little to do with biting or the bite. Positioning airway parts is about how to establish the most stable alignment of airway parts, the largest oropharyngeal volume, and the most advantageous airway posture for breathing during sleep. There are oral appliances of varying shape and size, but there is no one unique design of oral sleep appliance that can be placed just anywhere in the mouth and establish the optimal positioning of all related parts for optimal airway function and stabilization. Proper positioning of the airway parts prior to appliance delivery is essential for success of an oral sleep appliance. Design of an oral sleep appliance is one factor in maintaining the position of the stented, dilated airway. Proper relative position of the component parts of the oral airway, that's essential. Tongue, internal musculature, tongue, external accessory muscles, pharynx, hyoid bone, hyoid musculature, soft palate, and mouth space. Here are the guidelines for achieving excellent physiologic positioning of airway parts for an oral sleep appliance. You need parallel dental arches, the mandible and tongue anteriorly advanced. The mandible should be vertically lowered. Create optimal space for the tongue and the mouth. The tongue must be able to rest touching the roof of the mouth. The tip of the tongue must not protrude beyond the lips during sleep. The lips must be able to remain comfortably closed during sleep. The hyoid bone position should be advanced anteriorly, stretching the mylohyoid, and the hyoid bone position below C3, which gets less spinal curvature and a bigger oral pharynx. X-Slant makes it possible to achieve all these guidelines. The technique being shown presently is built on certain axiomatic principles, that is, unchallenged neurologic physiologic statements of truth. Axiom 1. In the upright human posture, isometric balance is the least stressful position for supporting the head on the spinal column. Okay, quick sketch here demonstrates that it is less stressful to support the head in an upright posture and more musculoskeletally stressful to support the head from an unbalanced posture. Isometric balance is a position of low nociceptive input to the brain. Nociception is the neural process of encoding noxious stimuli. Low clutter, high signal interference. Okay, more axioms. Low nociceptive input facilitates neurologic transmission and nervous system function. high nociceptive input, clutters neurologic transmission, and inhibits reflex activity. Okay, now we're on to today's demonstration. How to register an inter-arch relationship of low nociceptive input and low neurological clutter equals high facilitation. Okay, so we're going to use manual muscle testing to find out what neurological position his brain would like this device to register the maxillomandibular relationship to be in. So we use the muscles as an indicator, and the nervous system is going to tell us what to do. So we like someone who has not a sore shoulder. Both shoulders, Sid has said, are healthy. There's no soreness in them. We chose to use the right. What we ask them to do is lock your elbow, and then I'm going to push down on the arm, and you're going to resist. Start out, lips together, teeth slightly apart, tongue in the roof of the mouth. I'm going to push down, and you're going to resist. Ready? Resist, 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 resist. And that's very good. And he's quite strong. And then next we're going to get a standard. So we say, close on your back teeth, bite and clench hard. Lips together, tongue in the roof of the mouth. I'm going to push down, you're going to resist. Ready? Hold it up there and resist. And there's a huge difference. And you could feel it too. Mm-hmm. So now what we're going to look for, that's a position. What you look at and you think is strength is really what we call facilitation. The muscle didn't get weak. It's a position of facilitation. So now we're going to find the right position to put the appliance in. I'm inserting the tool for a trial measurement. Now when we ask the patient to bite down on your back teeth, what we find is that he's only hitting securely on this side, but there's a lot of play on this side. So what we need to do is to build up so that he bites evenly on both sides. Added a 0.5 millimeter to the one side. We have on this side, on the right side, we have 5.5 millimeters, and on the left side we have 6. And we put it in to test, and at 5 and 6, we're going to test again. Okay, holds his arm up here, and lips together, tongue in the roof of the mouth, lips together, tongue in the roof of the mouth, and standing up straight. Okay, I'm going to push down, you're going to resist. Ready? Resist, 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 resist. Okay, good. That's as strong as I think we're going to get it. This is about the 3rd try now. So, a little goop here. And a little goop here. And this goes to the mouth. The goop to the mouth. Put it in and bite. Hold it, hold it, hold it. Okay, now you can keep it on, and that's gonna, let's assume for a moment that that's set. So we're gonna tell him to slide forward, slide your lower jaw, good, forward and back. Okay, now we're gonna test. Let's test that right there, okay? Lock your elbow. Can you do that? Okay. And we're going to test. So hold it up and ready. Resist. It's okay. Not good. Now slide your lower jaw forward. Let me see. Good. Okay. Hold it out there and ready. Lips together. Mm-hmm. Test. Now that's really good. Okay, stop. So that's what we're going to do. So now, can you get this real close as you can? I'm going to put this, see it? Right there. And I put it between his teeth right there. And I go around to the other side. And I do the same thing. I squirt it under and above and between.
That's it. Okay. Good. Okay, now let it set a minute more. And we test. Okay, hold it up there. Lips together, standing up straight, tongue to the roof of the mouth. Hold it up, right there. Resist, 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 resist. I've got it. Okay. Now, at that point, I'm just going to do this to show that they could scan. They could scan, but if they don't have a scanner, we're going to fill it in. Okay? Now, wait, you see? Got it?
Mm-hmm.
Mark, you got it. Mark's on. Put your tongue in that little space there. That's perfect. Okay, put your tongue in there a little bit. Don't squirt it all out. That's it. Now we've done it. Sit there and smile at him. And that's the technique. That's what it's all about. Now, what you didn't understand, I don't think, is that then we take it out and goes to the lab. That's the bite.
Mm-hmm.
Yeah, that's the bite. And so, well, that's the bite. I'm telling them, yeah, no, that's it. And now, open, and they have it. That's the bite. And now we can take and trim this, and that's it. Off to the lab.
Okay, you just saw how I do it. If you are ready to begin registration of the inner arch position using Xlan, just go do it. And thanks for watching the demo. But if you want more orientation and scientific explanation, just stay tuned. The key word here is facilitation. We record the interdental position of the highest possible conditional facilitation. I register this position in the standing upright posture because it offers the least nociceptive clutter. No one ever sits up perfectly, and lying supine also introduces more anatomic clutter than standing upright. The goal is to stent and support the largest possible airway. Besides, when the patient lies down, there's no reason to think that this dilated, stented position shrinks. It stays dilated and stented. There is no good reason for the patient to be supine to register the bite. Tongue in the roof, here's the principles. Tongue should be in the roof of the mouth, creates the largest oral airway. Lips together necessitates nose breathing. Teeth apart, that's rest position. Low nociceptive input. Stand up as straight as you can, isometric balance, and that's how we get conditional facilitation. This demonstration did not measure muscle strength or weakness. It examined the response to a challenge to the central nervous system. Today's demonstration was isometric deltoid press. In isometric muscle activity, no movement occurs. Muscle contracts but does not shorten. By placing a limb in a specific position, single muscle isolation testing is possible. Gains in muscle facilitation occur only along the specific axis on which the muscle contracts. Do not confuse isometric with isokinetic muscle activity, where an isokinetic movement is a necessary component. The regulation of muscle function is basically accomplished at a subconscious level. Information provided within the muscle spindle cells and Golgi tendons generates signal outputs. Function and movement are generated by the premotor and motor cortex and sent to the reticular activating system, hypothalamus, and limbic systems. Manual muscle testing is not a parlor game. It is science presented using the same methodology as physical therapists, physiatrists, and chiropractors use every day. This is how they do disability evaluations, manual muscle testing, just as you saw it before. Just because it's so beautiful, I'm showing you a high-tech view of the human brain in neural network transmission. It's very complex, as you can see. So we try and simplify things. This slide is a map of the neurological pathway of the challenge to the deltoid muscle. The sensors initially receive the signal from the deltoid being pressed down and transmitted to the central integrative system where it is processed. And the result is instantly conveyed qualitatively via the deltoid press, because the question is being asked in a manner the central nervous system can unconsciously convey the answer. These slides may look like something on the GPS of your car, but they actually came from Neurology textbook. Manual muscle testing demonstrates the ability of the neuromuscular system to adapt to changing pressure, not the total or peak force the muscle can produce. Manual muscle testing is not a measure of strength. Based on its response to manual muscle testing, muscle status is said to be either inhibited, which is a proper term describing the inability to resist pressure over a 1 to 3 second period. Facilitated is the proper term for describing the ability to maintain the test position against gradually increasing pressure, again, over a 1 to 3 second period. Manual muscle testing is not indicative of pathology or disease of the muscles or nerves. The terms inhibited or facilitated are precise definitions related to neurological challenge. Manual muscle testing and the Xlan posterior stabilization guide provide a functional neurological methodology used to guide clinicians to a positioning of airway parts for optimal sleep breathing, muscular, skeletal, and postural functioning. Manual muscle testing and X-Slant posterior stabilization are utilized to determine an effective therapeutic starting position for oral sleep appliances. Usually, this is in a maxillomandibular position, elevated more vertically and more protrusively than rest position. Manual muscle testing is analogous to a wiretapper surreptitiously placing a miniature tracking device close enough to the circuit connectors in a junction box to receive signals without disrupting the transmission and then removing the tracking devices undetected. This slide shows a handheld dynamometer, an objective device to perform manual muscle testing. In many controlled studies, in numerous respected scientific journals, manual muscle testing has been shown to be reproducible. Okay, the conclusion. Manual muscle testing utilized with X-Slant posterior stabilization guides to determine the most facilitated position of the central integrative involuntary nervous system is a reproducible, reliable method to establish the optimum inter-arch relationship of nocturnal airway patency for initiating treatment of sleep apnea and snoring with an oral appliance. Manual muscle testing works, and utilizing manual muscle testing with X-Slants is the way to get what right? Optimal positioning of airway parts in an oral sleep appliance featuring parallel dental, interdental arches, and absolutely no elevator slant. Adios. Good luck, and let me know if I can help solve any problem in with airway dentistry.